let's begin. Share my screen. Hopefully you can see it now. Yeah, when I started to prepare this talk, I quickly realized that I could not do justice to the topic of today in 30 minutes. So anyway, some point emerged quite quickly. Redefining preclinical testing as we know it is not something that we should do in the future, but it is already there. We are more or less already in the middle of it. Yeah. So and that's why I'm going to present today only some aspects in this half an hour and try to explain why we believe that cell models, human relevant cell models, are at least one, if not that important part of the strategy for this new preclinical testing in the future. Okay, I think more or less everybody of you know a chart like this that shows the progress of drug development. One important aspect is that use the preclinical studies to predict what will happen in the clinical part. Yeah? And we can, for example, also use another kind of chart that you may also know that displays time that is needed for a complete development of a drug and also the shares of the different steps on the total costs. And what it also shows is the success. And if we look at this, then we immediately see that unfortunately our preclinical models seem to be not very predictive, because if we have in the preclinical tests, let's say 10 candidates or 20 candidates, then at the end we end up with 1 or 2 candidates, what means that 90% of all drugs that pass animal testing fail in human trials. So, and this is, of course, quite poor. Even if there, of course, are more reasons why drugs fail, despite that our animal models might be not perfectly predictive. It is a concern. Here I listed some very prominent examples of failures in which animal models were unable to predict the safety of a drug. Yeah? So one very prominent example is teralizumab. It's an antibody that is used or was indicated for autoimmune diseases, and you might know this problem that occurred here also under the name Elephant Man trial, because this antibody was tested safe in non-human primates, but when it was transferred into clinical trial phase 1 in 2006, it induced a very severe cytokine storm in all of the patients that were tested in phase 1. Yeah, so that was really very severe. And similar things happened to hyaluronidine, which was indicated for hepatitis B. And again, there were no liver toxicity in animals, but in when it went to clinical trial, there was a fatal liver failure. And as far as I remember, of the 15 people who were included in that clinical trial, 5 died by the treatment. Um, Vioxx is another example. Vioxx was marketed by Merck, and it was really successful because I think in 2003 the revenue of Vioxx was around 2.5 billion US dollar. So it was far from we want to take it from market, and it was safe and effective in animal models, but it induced or increased cardiovascular risk. And I think we had between 80,000 and 140,000 cases of serious heart diseases because of Vioxx. And that's why it was withdrawn in 2004. And of course, everybody, I guess, know this example, thalidomide, or better known under Contergan, was indicated especially also for pregnant women against morning sickness. And it was also tested in different animal species. But as we know today, it caused severe birth defects. I think there were 10,000, maybe up to 20,000 cases, and 40% of the people, or the young children around birth, died because of the treatment with thalidomide, treatment of the mothers. Yeah, so definitely, of course, these are very severe examples, but it shows that yeah, animal outcome is not always, or let's say in too many cases, it does not really completely reflect what happens in humans. Beside this problem of the poor predictability, animal models become more and more expensive. Yeah? So we have rising developmental costs because of the animal facilities and animal models. And of course, beside this concern or cost concern, there are of course also concerns regarding ethical and regulatory issues. Yeah, and the good news maybe is that regulatory acceptance remarkably increased during the last years. Here, for example, the EMA pushes what they call new approach methodologies, or NAMs, to reduce animal use. And this is in context of the 3Rs principle. 3R stands for replacement, reduction, and refinement of animal use. And the EMA really wants to follow that rule, as also the FDA some years follows what they call a phase-out animal plan. Yeah, so to reduce animal testing, and this is a development that began already 15 years ago. And let's say in the beginning, maybe the main reason was, of course, ethical concerns about animal testing. So in 2010, the OECD adopts the first guideline against animal testing, or for animal alternative methods. And 2 years later, the EU banned animal testing for cosmetics, for example. Yeah, and I think EMA EU was a little bit faster, but FDA, so the US authorities followed, and they also increased or supported then in vitro and silico methods. And in 2022, very important, what is called the FDA Modernization Act 2.0 was or passed in the US, and this for the first time allowed in the US the development of a drug without any animal testing. So before that, this was not possible. From law, it was not possible to get a drug completely through the development without any animal testing. And that is, of course, a big advantage. At least it is a law now. It is on the regulatory base. I think just this year there is what is called the FDA Modernization Act 3.0. So it has been returned to the Senate to increase the pressure on the FDA. So to really implement tools to get this Modernization Act 2.0, so the non-animal methods running. So let's say on regulatory level there is definitely things going on, but why do we believe that cell models might be one of the most important tools to reduce animal testing? From a scientific point of view, at least we can hope that they are more predictive. Of course, one big advantage is we can do cell models from human origin, of course. So from this point of view, definitely they should be more predictive, and at least if we can get them routinely running, they are also faster, and they also should be cheaper. But cheaper at the moment, we have to say that some of the more sophisticated cell culture models are not cheap. Definitely the wrong term to use for these cell culture models. And of course, what is also, of course, very, very important is that from an ethical standpoint, they are the better choice anyway. So what can we do regarding cell culture assays? So in our laboratory, for example, we use well-established cell culture models to check, for example, GPCR activation. We use stable cell lines for this, also to report the activity of genes. But the problem here is they are, of course, they are well established. They work very nice, so that we can use them in screening approaches for drugs, or we can use them in screenings and in quality control mainly. But the problem is that they, of course, lack any genetic heterogeneity. So and that's why they are not really suitable for preclinical testing. Because what we need there, if we really want an advantage against or advantage over animal models, is that we display the genetic heterogeneity of patients, of humans. And one possibility, of course, is to use PBMCs. We can isolate PBMCs from normal people, from patients. It is a very easy resource, and we can do a lot of assays with these PBMCs. And because we can get them from different people, we have, of course, also genetic heterogeneity. But the problem is, for certain indications, they are very well suited, so we can really use them, but let's say the indications are limited where we can use them for. Yeah, so it is a good tool, but only restricted to some indications. Another alternative, of course, are stem cells. So stem cells of human origin have a high potential. We can use them in different kind of systems, in 2D, the cell culture assays. We can use them to build up organoids, and also, of course, as organ on the chip model in microphysiological systems. They are very important tools now for us. And there are more or less 5 kinds of stem cells when we talk about human stem cells, which are embryonic stem cells, of course, then adult stem cells that we get from biopsies, for example. Then, of course, we have cord stem cells, and what is also very important, induced pluripotent stem cells and fetal stem cells. They all have different key features, come from different origins, and have a different level of potency. When we look at the challenges of the different types of stem cells, then we see that, of course, embryonic stem cells and fetal stem cells, they have fundamental ethical and therefore also legal issues, which make them a difficult choice for preclinical testings. If you look at the 3 remaining ones, then cord stem cells are very nice, but let's say the cell number is limited. Of course, we don't have them from all people, and the cell number is also quite limited, which make them also not a perfect choice when it comes to preclinical testing. So that's why I'm going to focus today on induced pluripotent stem cells, and to a lesser extent also on adult stem cells. Induced pluripotent stem cells also have their challenges, mainly genetic instability is a problem. This is because the reprogramming of the cells themselves can induce mutations or worse, chromosomal aberrations. But they have the very big advantage, of course, that they have a very high differentiation potency, so we can differentiate them in more or less all tissues that we want, and therefore we have a resource that is more or less not limited. Yeah, so these are the let's say a negative challenge, but the advantage definitely is very high when it comes to build up systems for preclinical testing. And as an example of an initiative that uses these induced pluripotent stem cells as an integral part, I want to introduce the SIPA initiative, which is an initiative for the evaluation of proarrhythmia risk. So proarrhythmia is the provocation, more or less, of a new arrhythmia or the aggravation of a pre-existing one during a therapy with a drug that is normally thought to improve the system. Yeah, so even at doses that we would not believe that they should be toxic. Yeah, so it's a very important risk evaluation, and CEPA is an initiative that was initiated by the FDA and the HWI. And in the meantime, there are partners from all over the world inside of this initiative. So it really has a high potential to produce something that in the future we can rely on. And what are the core components of the initiative? So it starts normally with a ion channel profiling. This is normally done in stable cell lines that are pressing these relevant channels, sodium channels, calcium channels, ERGs, all these channels that are important in this case. And then the data from these cells, they are used for an in silico modeling. So this is the second step. And then in a third step, these data, they are retested on this more sophisticated human-induced pluripotent stem cells, cardiomyocytes. So these stem cells are then developed into cardiomyocytes, and these cardiomyocytes, they have the advantage compared to these normal stable cell lines that they really resemble the physiology, the human physiology that is important in this respect. And then only in the latest stage of the assay there is in vivo QT assessment. Yeah, but this is more or less this is only for confirmation, not really for prediction. The prediction is really done by this system. And in the meantime, there is a very high regulatory and industry acceptance. The FDA uses the results from the CEPA initiative and introduces this into guidelines. The ECH E14S7B is an example for this. Yeah, so this is really a successful example for using of these kind of stem cells. There are other examples. I will not go into detail because of time, but there are definitely other examples which also uses stem cells in their models. And in the last 5 minutes, I want to go to another system that we can use in preclinical testing. These are organoids that can be formed from stem cells, also from adult stem cells. So we can also use, for example, cancer tissue. We can build up these organoids in detail because it's too complicated, but we can really build up different kind of tissues with these stem cells, which we can then test mainly in toxicology approaches. And in the meantime, a lot of different organoids. 4 I have listed here. About cardiotoxicity, I've already talked with the CEPA initiative. Of course, there are very good organoids in the meantime for hepatotoxicity, maybe more or less the best models are liver on the chip models today. Then we have also brain organoids for neurotoxicity, which is interesting. There is a very nice project of the B Farm together with the Life and Brain here in Bonn, where they test the metabolic activity of these brain organoids, which is important because the brain has also metabolic activity, and this is together with the blood-brain barrier a very interesting model. And it is very difficult to test this in vivo, but with organoids, it's possible. And also we have very nice kidney organoids. So, because time is running, I just want to emphasize some of the advantages and maybe also disadvantages or challenges, I would say, that we still have with use pluripotent stem cells. Of course, we already talked about human relevance because they come from human. Yes, we have the possibility to use them into very different cell types. We have an unlimited supply. So if you have a cell line, EPSC-based cell line, you can freeze them, you can use them. So this is, of course, a very big advantage because they are have more physiological functions than, for example, tumor cell lines. We can really, regarding stress testing and things like this, we can really produce very reliable novel endpoints, which is definitely interesting when it comes to personalized and disease-specific models. Of course, we can help us reduce animal testing and therefore fulfill the 3R principle. And what is also interesting, if you have a cell system or organoid system, it is much easier to get a mechanistic insight what is going on if something is toxic when compared to a complete animal. So this is also then gives the researcher a possibility to really get a mechanistic insight. On the other hand, there are limitations. These cells are to a high extent immature, means that some of the functions that they display are not the physiological function of adult cells. That is sometimes a problem. Then, of course, the development or production of a certain cell type is not always 100%. So we have a phenotypic variability inside of the cultures and, of course, between different cultures from different, for example, from different biopsies. Of course, this is always the case. We cannot, at least nowadays, we cannot resemble the complexity of an in vivo environment with these cells. This is clear. And because these cell cultures, normally we have them for a limited time, it is not that easy, at least up to now, to measure chronic exposure. And we know that some problems appear only after chronic exposure. Throughput and scalability is still a challenge, but I think this will be solved one day. And of course, we have to learn to interpret the data, and we have to develop standards. This is also still quite limited, I would say. And of course, cost considerations against animals is good. Against traditional cell models, I would say it's bad because they are still very expensive. Okay, but I hope that this could convince you a little bit that the shift has already begun. We are in it already. There are some of the important players are on board, and in the beginning, maybe the goal was to replace animal tests, but I think we have learned that this is only one goal, but another very important goal is that we can use these systems to really build better science, to get safer drugs and to get a better prediction for clinics. And this should push us forward to. Okay, I hope I could tell you some new aspects, interesting aspects. Thank you for listening.